Our next speaker is Dr. David Eichenbaum. Dr. Eichenbaum serves as Director of Research for the Retina Vitreous Associates of Florida. He's a highly published researcher and clinician and a leading clinical investigator in over 70 clinical trials with a focus on neovascular retinal diseases. Dr. Eichenbaum will be discussing angiopoietin and Tie signaling in more depth, and he'll describe the interactions between angiopoietin 2 and VEGF in neovascularization.
I'm David Eichenbaum, Director of Research at Retina Vitreous Associates of Florida and Collaborative Associate Professor at the Morsani College of Medicine. And I'm excited to talk beyond VEGF today about the role of angiopoietin 2 in retinal vascular pathology. I'm collaborating with the Angiogenesis Foundation and Genentech for this project. Something striking going into the 2020s is that we're moving beyond the VEGF era, which has possessed us for the last 15 years and seen a revolution in patient care. However, we're heading to the next phase, looking at combination therapy, looking at extended release therapy, looking at devices, looking at gene therapy, looking at novel imaging, AI empowerment of our imaging databases, and all kinds of things that hold a lot of promise. We know that VEGF alone does not fully explain the pathophysiology of common retinal diseases. And today we're going to focus on something else, on another factor. This is because when we treat patients with anti-VEGF monotherapy, we see that in clinical practice, fewer injections are associated with poor visual outcomes. And this paper is very famous work published by Frank Holtz. It looked at the EU and UK experience. And what this showed is that anti-VEGF treatment resulted in initial improvement in visual acuity. However, this was not maintained over time. The visual acuity decreased back to baseline over time. And if the data is split out between countries, as it is in the paper, the countries that had a fewer mean number of injections had an even more rapid and dramatic decrease in visual acuity over time. And the countries that had more robust visual acuity maintenance. Regardless, on average, nobody did well because anti-VEGF monotherapy requires a very high treatment burden. Ang-2, which we're going to focus on today, is one other factor that enhances vascular permeability induced by VEGF. How do we know this? Well, there's a lot of basic science supporting Ang-2's role. In this basic science model, which is the Miles assay, it looks at both wild-type mice, which is the graphic on the top left, and Ang-2 knockout mice, which is the graphic on the bottom left. The wild-type mouse, when it's perturbed with either control, which is a saline injection into the skin on the left side of the graphic, or VEGF, which is a VEGF injection into the skin on the right side of the graphic, we see leakage of dye. If you look at the picture below the wild-type mouse, at the Ang-2 knockout mouse, when either control or especially VEGF perturbation of the tissue is performed, there's a dramatic decrease in vascular leakage in this Miles assay of mouse skin. Looking at this model, looking at a single endothelial cell layer, you can measure the endothelial cell layer's integrity over time. This is an experiment called transendothelial electrical resistance. Looking at the endothelial monolayer, untreated over 25 hours, about a day, the cells do pretty well. The integrity is preserved over time with only a slight reduction in endothelial integrity. If you add in our old enemy, VEGF, you see that the tight junctions are rapidly compromised. There's a substantial decrease in endothelial integrity following the introduction of VEGF. Now, if you start to counteract that with the addition of angiopoietin 1, a good actor, a vascular stabilizer, you see tightening of the cell-to-cell junctions. If you add in anti-Ang-2, add in an agent that works against angiopoietin 2, the pro-destabilizing bad actor, if you will, you see a further resolution of the endothelial cell layer. If you add in both anti-Ang-2, anti-bad actor, and Ang-1, some good actor, you see a further stabilization of the endothelial monolayer over time. One could imagine adding in anti-Ang2 and Ang1 with a current potent anti-VEGF and perhaps having further restoration of the endothelial monolayer over time. There is an interplay of VEGF and Ang2, and the overexpression of Ang2 in the presence of VEGF disrupts the vascular architecture and function and is a pro-permeability setup in common pathophysiologic states. This paper and the following series of slides shows that ischemia is a pathological context for studying Ang2 and VEGF in vascular structure and function. We'll see an experimental animal model where there is an ischemic event, and early perfusion recovery of the ischemic hind limbs in the experimental animal does not improve upon introduction of VEGF-A. In fact, it worsens slightly, but decreases further after combining VEGF-A with angiopoietin-2, as we're going to show in some detail. Let's take a look at some of this series. Here, we see that adding in Ang2 to these ischemic tissues shows a further reduction in perfusion. On the left, we see control, where there's a femoral artery ligation in an experimental animal, and 7 days later, you see that there is vessel perfusion that has recovered to some extent with control. When you add in VEGF-A, you see that the vascular perfusion is not quite as good. When you add in VEGF-A and Ang2, you see a further reduction in the recovery of perfusion. You see that Ang2 in the ischemic setting is a bad actor for recovery. Similarly, adding Ang2 to VEGF shows a reduction in pericyte coverage recovery following experimental animal ischemic injury. In the model again, femoral artery ligation occurs on the left side. There's 7 days for the animal to recover. And what we see is that pericyte coverage does recover to some extent, of course, not to baseline following ischemic injury with no treatment. When our old enemy VEGF-A is added, there is a reduction in the robustness of the recovery in the middle column. On the right side, when VEGF-A and Ang2 are both added, this is a combination of bad actors that further reduces pericyte recovery in the ischemic animal. Here we see that overexpression of Ang2 compromises the tissue. What we see here in the Ang2 double transgenic animal traced in red and the wild type animal traced in blue is that we have femoral artery ligation. And after that, there is a reduction of blood flow. There is reperfusion allowed. And what we see over time is that at day 3, the wild type animal begins to recover, and the double transgenic Ang2 animal does not recover as well. As time passes, there is a continued and persistent 50% reduction in the recovery of the animal that has Ang2 induced in this ischemic setting. That's a big difference, implying the role in lower mammals of Ang2 limiting recovery with ischemic tissue. Here we see the collateral artery size, and we see in the wild type animal versus the Ang2 double transgenic animal, we see that this is probably why there is so much less recovery. There is just less collateralization when Ang2 is heavily involved in ischemic injury in the experimental animal. VEGF inhibition, such as what we do in the clinic in our patients with common retinal diseases, can lead to an upregulation of Ang2 itself. Here, we see in glioma that inhibiting VEGF allows increased expression of Ang2 in the mouse model on the left and increased vascular permeability in concordance with that in the assay in the same model on the right. On the left, we see pre-treatment that there is a certain level of Ang2. Anti-VEGF is introduced And initially, Ang-2 may be suppressed, but as time passes over the first 8 days, there is a remarkable increase in the level of Ang-2 in the mouse tumor. Similarly, looking at the vascular permeability on the right, following the introduction of anti-VEGF, there is a reduction in permeability, and by day 8, there is a profound increase in permeability in concordance with the increase in Ang-2 levels. That's striking. And if we're inducing Ang-2 elevation in the human clinical setting in retinal disease, we may be seeing the same leaky effects, wondering why they're there. Well, it's because the Ang-2 is upregulated in higher mammals as well. There we see the day 8 statistically significant difference in tumor level Ang-2 and vascular permeability. Inhibition of Ang-2 in preclinical models of choroidal neovascularization reduces leakage. This is a cynomolgus monkey who has laser-induced choroidal neovascularization. On the left side, we see control. There's profound leakage from the laser-induced CNV. In the middle, we see anti-VEGF-A showing what we would expect, which is a reduction in leakage. On the right, we see anti-Ang-2 monotherapy, which also shows a reduction in leakage. One can imagine how a combination of VEGF inhibition and Ang-2 inhibition could result in an even better and perhaps synergetic reduction in leakage in this particular mammalian model. Inhibition of Ang-2 and VEGF-A in a similar model in the transgenic mouse that has a propensity for CNV, we see that either inhibiting the CNV with VEGF in the middle photograph or with Ang-2 in the photograph on the right show a reduction of leakage in this preclinical mammalian model. VEGF-A, we know, increases neovascularization and permeability. You see proliferation, migration, tube formation, permeability, and inflammation with increased VEGF-A. With increased Ang-2, we see vascular instability. We see cellular decoupling, pericyte dropout, permeability, and inflammation. You see similar effects from these two cytokines. What you don't see is perhaps the synergetic effects of these two cytokines and how there's an interplay between them. Ang-2 and VEGF are both biological modulators of neovascularization, permeability, and inflammation, and when they're overexpressed, there's a similar contribution to retinal vascular disease and its progression. In this cartoon, we see here the VEGF-driven functions of neovascularization. Vascular sprouting and neovascularization and progression of choroidal and retinal vascular diseases are directly related to VEGF. Here, we see upstream, even though perhaps happening simultaneously, a number of other steps in pathophysiologic vascular diseases which are not directly related by VEGF, and perhaps they're mediated by Ang-2 instead. Ang-2 is upregulated in common retinal diseases such as neovascular macular degeneration, diabetic retinopathy, and retinal vascular occlusion. And Ang-2 then outcompetes Ang-1 for the Tie2 receptor in step 1. When that happens, there is then a loosening of endothelial tight junctions and an increase in inflammation. This increase in inflammation and transmigration of associated cellular products related to the inflammatory increase destabilizes vessels by causing pericyte dropout. That pericyte dropout, directly related to the preceding step of inflammation, then sensitizes vessels to the subsequent steps mediated by VEGF, vascular sprouting, neovascularization, leakage, and progression of disease. So the interplay between Ang-2 and VEGF is seen in this beautiful graphic, starting on the left side with the increase in angiopoietin-2 in retinal pathophysiologic conditions. In summary, Ang-2 facilitates vascular permeability along with VEGF. Preclinical models demonstrate that Ang-2 destabilizes neovasculature and increases permeability. Beyond the role of VEGF, the contributions of Ang-2 expand our understanding of pathological features of neovascular macular degeneration and diabetic eye disease. And overexpression of Ang-2 may contribute to progression of retinal vascular disease and resistance to anti-VEGF drugs. Thank you for your attention to this segment focusing on angiopoietin 2.